Hi, my name is Saeed Khadir. I'm consultant physician and endocrinologist in Al Habib Medical Hospital or Medical Complex in Ulayya in Riyadh. I'm going to speak today about insulin therapy in managing diabetes. First of all, insulin being the oldest drug, and it's very drug in treating diabetes, both type 1 and type 2 diabetes. But there are certain barriers to prevent us from using type 2 diabetes, from using insulin in type 2 diabetes. So I'm going to speak first about managing type 2 diabetes. After you manage your patient with oral hypoglycemic agent, after failure, because the majority of type 2 diabetes will have beta cell failure after 10 or 15 years because it's a progressive disease and there is beta cell failure. One of these barriers first is the fear of the patient, because the patient, he doesn't like insulin and he thinks that he failed. The second problem, or the second barrier in using insulin in type 2 diabetes is the fear of the physician and the other complications of the insulin like hypoglycemia and increasing weight. And there are psychological problems as well, that the patient himself has a fear from the insulin and he thinks by taking insulin he is failed in managing his glycemia. Insulin, there are too many types of insulin. We have basal insulin or long-acting, intermediate or long-acting insulin, and we have the short-acting insulin, like the short-acting which it works only, start from half an hour and stay for 4 hours, called short-acting insulin. The basal insulin, usually we use it once daily, like glargine, and sometimes we use twice daily, like the NBH. We have two basal insulin at the moment currently as pen. There is a glargine and we have ditimir, and we still have the NBH insulin like the insulitard, which usually we use it in a pregnancy as well. When we use basal insulin, called basal insulin, it is two types, as I said, for two companies, one called the glargine, the other one is ditimir, and usually we give it once daily. It lasts for 16 to 24 hours. It is effective drug, and we can use it especially in type 2 diabetes, who the patient doesn't like to take too many injections. So he will take one injection plus his oral hypoglycemic agent, and it usually peakless. It will improve the fasting blood sugar and postprandial blood glucose. If the patient, especially type 2 diabetes, on oral hypoglycemic agent and started basal insulin, we initiate basal insulin. We start a small dose, like for example 10 units. We give it either at night or in the morning, and we follow the patient and we adjust the dose of his basal insulin according to his fasting blood sugar, and we can titrate the dose every 3 to 5 days by 2 units according to the fasting blood sugar. There is no major side effect from the basal insulin. It might give occasional hypoglycemia and might increase the weight slightly, but it's not major problem, especially if you educate the patient and you explain to him that if he has symptoms of hypoglycemia, to take just blood sugar and not to increase food. And any patient with education and sticking to healthy diet and exercise, probably is not going to have major problems in gaining weight. Regarding the bolus insulin, which is usually we give it before meal and usually before each meal, sometimes we do it 3 times daily, especially in type 1 diabetes. But in type 2 diabetes, we can use basal insulin once daily and +1. For example, we can give him short-acting insulin or bolus insulin at main meal. And if he's taking 2 main meal or 2 heavy meal, we can give him, for example, at lunch and at dinner. And in some patients, they might need 3 times daily basal bolus insulin plus the basal insulin. In type 2 diabetes, especially in elderly, they might not need more than just basal insulin +1 bolus, which is at the heavy meal. And this is probably enough for those type 2 diabetes who are already taking oral hypoglycemic agent to have only bolus, just one, and basal insulin. If the patient develop hypoglycemia, we can decrease the dose, or we can decrease the dose of his oral hypoglycemic agent gradually, and sometimes we might need to stop it. A lot of patients type 2 diabetes, they need at least the metformin to continue, plus the basal insulin and bolus insulin, either +1, +2, and occasionally we need to switch to basal bolus insulin. The bolus insulin, the short-acting, at the moment, currently we are dealing with just Actrabid. These are the short-acting insulin available here in Saudi Arabia. Usually it works within half an hour to 1 hour, and it lasts in the body up to 4 hours. It is very effective drug, and it is good in lowering the blood sugar. Usually we give it before meal, or now with the new generation, we can give it immediately before meal, not half an hour before meal. And if the patient forgot to take it, he can take it even after meal. The other type of insulin which we use it here is the pre-mixed insulin, which is usually mixed insulin, short-acting and long-acting, or the NPH. There are many types. The pre-mixed insulin, it is a fixed dose, and sometimes it's difficult to adjust the dose. It's not like the basal bolus insulin. So usually we give it 2 times daily, and on some patients we might need to give it 3 times daily. And I'll speak to the premix, some of the limitation why we cannot adjust the dose as the basal bolus insulin. It is a good drug, being used for a long time, and we can use it for those patients doesn't wish to have 4 or 5 injections. What are the indications when we are giving the insulin in diabetics? All patients with type 1 diabetes, they must be on insulin only. There is no other treatment for type 1 diabetes. Type 1 diabetes, as you know, affect young people, and also the insulin indicated in all pregnant ladies with diabetes, either type 1 or type 2 or gestational diabetes. So those pregnant ladies, if they have type 2 diabetes, we have to stop oral hypoglycemic agent and start insulin during pregnancy. The other type, gestational diabetes, we must use insulin only. The other indication for insulin, usually patients type 2 diabetes admitted to the hospital with acute illness, usually or probably better to use insulin to achieve better control during his pregnancy, during his admission to the hospital. The other things, those pre-operative or he's going to have a surgery, better to be on insulin to adjust or to improve his blood sugar before operation, after operation. Those patients also type 2 diabetes admitted to the coronary care unit should be on insulin as well, and probably we can keep them for a month or so after discharge from the hospital. What about type 2 diabetes? Type 2 diabetes, usually elderly or young people here in the Middle East, even affected 30 years old, but they are obese. We try to start with lifestyle, metformin, exercise. After that, we add oral hypoglycemic agent first, and if after 3 months his HbA1c is still not controlled or we are not achieving the target, we add another oral hypoglycemic agent, and we can, after 3 months again, another oral hypoglycemic agent. And there are too many drugs available in the market at the moment, and according to all the guidelines, the American guidelines, European guidelines, etc., you can follow them. We have to follow our patient. If we are not achieving the targets that you put in your clinic for your patients, we have to consider insulin. We should initiate insulin as early as possible to prevent the complications of diabetes. We need to achieve the targets, the glycemic control, according to the individuals as soon as possible. We should not leave the patient waiting for him to achieve a good glycemic control only on oral hypoglycemic agent. Most of type 2 diabetes, most patients with type 2 diabetes, according to UKPDS study, after 10 or 15 years, they are going to have oral hypoglycemic agent failure, and they will not respond to tablets only, and they need insulin. Because on the day of diagnosis of type 2 diabetes, probably 50% of beta cell being failed, and every year the patient will lose 5%. So within 8 to 10 years, maximum 15 years, the majority of our patients, they need insulin. As I said, type 2 diabetes is a progressive disease. Yes, we start with lifestyle modification and oral hypoglycemic agent. I said you can combine 1 or 2 or 3 up to 4 or even more. until we said that this patient needs insulin. Once the patient needs insulin, we have to explain to the patient that this is not your fault. This is the nature of the disease. It's a progressive disease and you will need insulin, and we have to explain to him. If we educate our patient and if we work as a team, including diabetes educator, dietitian, the physician, and you can show the patient that the insulin now is not something difficult to inject. If you show him the needle, it's very easy to inject. So we can break the barrier because the patient fear from the needle. Without seeing the needle, we can calm that because speak to them. If he refuses first or second time, we need to communicate with our patient more and more until we convince the patient to prevent the complications. If we explain to our patient that the complications of diabetes that include retinopathy or affecting the eyes, peripheral arterial disease, coronary artery disease, vascular and micro and macrovascular complications, certainly the patient at the end will agree to start insulin, and we can start him just on basal insulin and keep him on his oral hypoglycemic agent, and gradually we can adjust the dose of his insulin, and we can teach him how to adjust his basal insulin. There are too many guidelines and too many guidelines to follow how to initiate insulin. But the simple way is to start basal insulin in type 2 diabetes once either you choose at night or in the morning, for example, 11 p.m. in the evening or 11 in the morning. Once daily, start a small dose, for example, 10 units, and you can ask your patient to check his fasting blood sugar every day, and if his blood sugar, for example, remain above 130, you have to yourself to individualize the patient, and you put the target of his fasting blood sugar. If he is young and his blood sugar fasting more than 130, continuous every day for more than 3 to 5 days, you ask the patient to increase the dose, for example, by 2 units. If the patient is obese and think resistant, probably he can adjust the dose by 4 units. So every 3 to 5 days, you can ask your patient to increase the basal insulin. If your patient develop nocturnal hypoglycemia while you are giving the basal insulin at night, you can go back and decrease the insulin by 4 units. Or if he is on high dose of sulfonylurea, you can decrease the dose of his sulfonylurea and continue the basal insulin. While you are monitoring the blood sugar of your patient, pre-meal and post-meal, and you think that he has very high post-meal or post-prandial blood glucose, for example, after lunch or after dinner, you can add short-acting insulin just once at the main meal, for example, at lunch or at dinner. And after that, probably your patient, he might need basal bolus insulin. You can give him short-acting insulin before breakfast, before lunch, before dinner, and basal insulin once daily. If the patient presented to the clinic with severe osmotic symptoms, severe symptoms, even newly diagnosed, and weight loss, probably he is insulin deficient, you need to consider using insulin immediately, and after a while, if his blood sugar improves, you can stop his insulin. But certainly some patients, newly diagnosed type 2 diabetes, have severe symptoms, very high blood sugar, very high HbA1c, you might need to consider and initiate insulin, what we call early insulinization, to improve his symptoms, improve his blood sugar. This will probably help in preserving the beta cell of his pancreas. But I mean, if the patient is symptomatic, having weight loss, we need to consider insulin even if he has type 2 diabetes. And certainly all type 1 diabetes, they must be on insulin, as I said. The other things, any patient presented to the hospital with diabetic ketoacidosis, certainly this patient, the only treatment is insulin and IV fluid, and there is no need to start oral hypoglycemic agent. This patient most likely to be type 1 diabetes or something else we call LADA, but even type 2 diabetes on occasions, they can be presented with diabetic ketoacidosis, or some of them presented with something called hyperosmolar non-ketotic syndrome, very high blood sugar, and they've been unwell, admit to the ICU, and start them on insulin. If you decide to start insulin, to initiate insulin for your patient, either type 2 or type 1 diabetes, or in gestational diabetes, or in type 2 diabetes in a pregnancy, we need to explain to the patient what's insulin. The most important thing is the education of our patient, because we need to educate patient how to inject the insulin, where to inject the insulin, how to use the pen, and how to adjust the dose of his insulin according to his or her meals and exercise. The other things we have to teach our patient is the symptoms of hypoglycemia, because we need to avoid hypoglycemia as much as we can, because it's very, very important to avoid hypoglycemia. And at the same time, it's important to improve the hyperglycemia, but we need to also prevent hypoglycemia. The only thing is education for our patient, and certainly we have to teach them, and we have to work as a teamwork. If you have diabetes educator, if not, you have to educate yourself, the patient in your clinic. You have to show them, if you're going to use the pen or the needle, how much the units and how to use the needle and where to inject, usually subcutaneous. Either you choose the abdomen surrounding the umbilicus, or the thigh, or the arm. The other things, we have to teach our patient to rotate, not to give the injection all the time in one site. We have to rotate the site of injecting insulin. We have to explain to our patient about what type of insulin, how it works, and how long. And certainly, as we said, we have the basal insulin, regular or short-acting insulin, and the premix insulin. The advantage why we need to use insulin, as we said, insulin is very old drug, very effective in improving the blood sugar. There are no side effects apart from increasing weight on some patients and hypoglycemia, but there is no other disadvantages for insulin. The advantage, it is the most effective drug in lowering the blood sugar, and very little side effect, and certainly it will improve the hyperglycemia whatever the age of the patient and in any situation. If the patient is old or young, certainly insulin is the most effective drug so far. The disadvantage of insulin, as I mentioned, is increasing weight and going to increase by 2 to 4 kilograms. And if we educate our patient not to eat too much and stick to healthy diet and doing exercise, certainly the weight gain will be less than expected. Some patients, we don't know why, their weight increase too much, especially those with insulin resistant, requiring too much insulin. At the same time, they don't stick to healthy diet and they are not exercising. So we have to look at our patient and see if my patient is motivated, understanding the principle of insulin, and if he can stick to healthy diet. And nowadays we can use even insulin and the new drug to lose weight, for example, like the GLP-1 receptor agonist. And there are certain drugs coming as well, like SGL2 inhibitor. We can combine it with insulin. So we are not going to use too much insulin units. And at the same time, probably we are not going to increase much the weight of my patient or our patient. Hypoglycemia, as I said, this is the only or the major side effect of insulin, but certainly the number of hypoglycemia attacks will be less if you educate your patient. And at the same time, if you ask your patient to have snacks between meals, and it is very important for any patient on insulin to carry a paper or a card with him that he is on insulin, and if something happened to him, so the people will know that he has hypoglycemia and they can treat him. And we need to consider for our patient who is on insulin, especially children or young adolescent, especially those going to school and university, to speak to the people there, to the teacher, to the head teacher, that I am diabetic, I am in insulin. If something, symptoms like sweating, or if I start to have confusion or tremor, or feeling very hungry or unable to speak, to give me sugar and to check my blood sugar. The other things, we have a lot of young people who have type 1 diabetes, they are on insulin, and they are a driver, we have to warn them if they have symptoms to stop their car and to have sweets to treat their hypoglycemia. And in type 1 diabetes, sometimes we may need to consider giving them, as we said, to have a card with them to explain to the others that this patient has hypoglycemia and they need sweets. If we need to have a good balance between treating the hyperglycemia and avoiding hypoglycemia, the education is important. As I said, that educate the patient, educate and educate. The other things is to avoid or to have regular meals and to have snacks between meals. The other things, we have to educate the patient about the symptoms of hypoglycemia. If he is young, we have to educate his family, his parents, about the symptoms of hypoglycemia and to check on their young boy, for example, even at night, if he has any symptoms. And sometimes we need to check his blood sugar before he go to bed. There are now certain insulin, for example, the basal insulin, the number of hypoglycemia, if we are going to use basal insulin, is less than using a premix insulin, for example. So certainly using basal insulin, the number of hypoglycemic attack will be less than using a premix insulin 2 times or 3 times daily. The other things for this basal insulin and oral anti-diabetic drug, certainly the number in many studies, the number of hypoglycemia is less, and probably reaching the target of his glycemic control may be as good as premix insulin. But certainly the number of hypoglycemia will be less. So in type 2 diabetes, we suggest oral hypoglycemic agent and metformin to continue, plus the lifestyle modification, and once daily basal insulin might be enough, especially in elderly people, and it's enough also to achieve a target of HbA1c around 7%, but you have to individualize the patient. Some patients who are elderly with comorbidity, probably you need their HbA1c to be 7.5 to even 8%. Young diabetic patient, probably you need to say that this patient, his HbA1c to be around 6.5 to 7%. At the same time, we need to be sure that the number of hypoglycemic attacks is be the minimal. So we need to avoid hypoglycemia by education, having snacks between meals, and adjust the dose. Explain to the patient how to adjust the dose of his insulin according to his meals, his blood sugar readings, and exercise. There are too many guidelines and too many algorithms. There is no need to choose one, but there is the ADA guidelines, there is the British guidelines. You might need to have even in your hospital local guidelines how to initiate insulin. But certainly we need to depend on the type of diabetes. If he has type 2 or type 1 diabetes, the weight is very important. Those patients who are obese or overweight, or what we call them insulin resistant, they might need more insulin than those young, thin diabetic patients. So certainly we need to start the minimum dose, start with minimum dose, and gradually increasing the dose of their insulin according to the blood sugar readings and to their lifestyle and also exercise. Those patients going to exercise or going to walk, we might ask them to decrease the dose of their insulin or eating more. So it's very important to avoid hypoglycemia. If we need to start the basal insulin, it could be at bedtime. For example, if we are going to use glargine in type 2 diabetes, we keep them on their metformin and other oral hypoglycemic agent and start basal insulin at night. Start with 10 units. And as I said previously, we have to monitor this by checking their fasting blood sugar for 3, 4, 5 days, consecutive days. If his fasting blood sugar remain above the target that you put it in your clinic, for example, above 130, we increase the dose by 2 units. So we keep increasing the dose every 3 to 5 days until his fasting blood sugar around 130 or less. If he develop hypoglycemia and there is no explanation, for example, not missing his meal, probably we need to decrease the dose. When we decrease the dose, we need to decrease it by 4 units, not only 2 units. The other step, when we are going to use the insulin, we have to recheck his HbA1c every 3 months. If we are not reaching the target of, for example, HbA1c of 7%, we have to increase the dose, and we have to depend also on self-monitoring blood glucose to see when this patient having, is it high fasting blood sugar, or some of them, they have only very high postprandial blood glucose. If his fasting blood sugar is still high, it means we have to increase the dose of his basal insulin. If his postprandial blood glucose, for example, after lunch or after dinner, the blood sugar is still high, in spite of taking oral hypoglycemic agent, we might consider adding bolus insulin or short-acting insulin at one meal, for example, at a meal, at lunch, or at dinner to improve the postprandial blood glucose. Regarding the targets, as I said, this is individualized. It depends on the patient. Those young patients, you can put a target for HbA1c to be between 6.5 to 7%. Elderly people with comorbidity, 7.5 to 8%. But this is according to the recent ADA guideline and ESD 2015. It depends on the patient himself. And you are a physician in your clinic. You have to decide what's the target for their HbA1c or their blood sugar. But certainly we need, ideally, the postprandial blood glucose to be less than 150, and for his fasting blood sugar to be between 90 to 100. And some patient may be elderly with comorbidity. Any postprandial even up to 100 or 200 is acceptable, and their fasting blood sugar up to 130, 40 is acceptable, because in elderly people with comorbidity, tight blood sugar is not good for them and might lead to side effects in addition to more hypoglycemia. How to intensify the dose of insulin, which is the step 2. After you start insulin, you ask your patient to monitor their blood sugar, usually fasting blood sugar or pre-meal and post-meal, 2 hours for meal. Usually we check it before each meal and 2 hours after meal. Sometimes it's difficult for the patient to check their blood sugar frequently, but at least you need the fasting and at least 1 or 2 readings post-meal. It's important to check also a pre-meal, but we have to encourage the patient to do self-monitoring blood glucose. We have ourselves as a physician or the diabetes educator to review his records or his blood sugar records on each visit, and we will teach them how to adjust the dose. If his fasting blood sugar is still above the target, as I said, we have to increase the basal insulin. If his postprandial blood sugar is high, we need to increase or adjust the dose before the meal. If his post-lunch blood sugar is high, probably we need to increase the dose of his pre-lunch short-acting insulin. Making the adjustment depending on the patient's age, depending on the type of insulin, and if your patient is young or old, and we need to avoid hypoglycemia, we can titrate the dose gently by just increasing the dose by 2 to 4 units every few days. When you reach the target, if your patients after 2 to 3 months come back to the clinic and he has HbA1c around 7%, for example, and his fasting blood sugar in the range which we accepted, and his pre-meal and post-meal is okay, we will continue the same dose of his insulin. If his fasting blood sugar is high, I said we can increase the dose of his basal insulin if he is on basal bolus, and if his 2 hour after meal is high, we can increase the dose of his short-acting before each meal, depending on the meal when his postprandial. If his postprandial after lunch is high, we need to consider increase the short-acting before lunch, increase the dose by 2 units or 4 units, depending on the patient. Step 3, if we still having poor glycemic control, we have to check if the patient is really taking his insulin or not, because we have a lot of poor compliance. A lot of patients have poor compliance and they are not taking their insulin. The other things, we have to check his technique, if he is taking the injection at the right site, and also probably we need to ask the educator to see the patient where he inject, how he inject. The other things, we have to check the insulin. If the insulin in the refrigerator or he left the insulin in the room. So it's important to check the bin of the insulin, to check the technique, to check the site. And sometimes we might need to rotate the site of the insulin, not to just have his injection at one site, because the absorption will be less. The other things, we need to be sure that the insulin being really in the refrigerator, not outside. And the other things, if he is injecting the whole units. A lot of patients, they don't know how to inject, so we have to teach them and be sure that our educator or the diabetes educator or you as a physician know that your patient is taking the right injection and the right number of units. Premix insulin, I said some patients, they prefer, and we used to use it before we have the basal and insulin, we used to give a premix insulin. Usually we give it 2 times daily, and on some patients we can use it 3 times daily, because there is a study done for the Novo mix being given once or twice or 3 times daily. It depends on the patient, but the majority of our patients, they have premix insulin twice daily, before breakfast and before dinner. Some of them, they have it also at lunch. So we can give it twice daily or 3 times daily. And in pregnant women, sometimes we give the Novomix 50, or the Humalog 50 up to 3 times daily to have better control of their blood sugar. In a premix insulin, it's very difficult to adjust the dose. It's not like the basal bolus insulin that we can adjust the dose according to the meals and the blood sugar reading. So we have some difficulties sometimes to adjust, because it contains both the short-acting and long or intermediate-acting insulin. So in summary, we can say that insulin is one of the best drug to treat blood sugar or to treat hyperglycemia, to treat diabetes, type 1, type 2 diabetes, gestational diabetes, and any type of diabetes in a pregnancy. It is very safe, very effective. Its injection, up to now, there is no oral insulin. And there are other things which we can use in young people or those patients very difficult to achieve the target and poor compliance, or if their blood sugar is erratic, something called insulin pump. Insulin pump, we can consider it in some patients, and it needs an education and teamwork. It is available, and we give it to the young people or those with erratic blood sugar and difficult to control their blood sugar, and those patients having a lot of hypoglycemia and hyperglycemia. So there is insulin pump, which is available, and it's suitable for young people or adolescent, even elderly, and also we can consider it during a pregnancy. But the home message for you as a physician, that please try to start insulin when the patient needs insulin. If the patient failed to achieve a target of their blood sugar, failed to achieve the HbA1c that we put it for our patient, for example, 7%, and he, in spite of lifestyle modification and being on maximum dose of oral hypoglycemic agent in type 2 diabetes, we have to initiate insulin. We should not leave the patient without insulin for a long time, because we need to prevent the diabetic complications, especially the microvascular complications. Insulin, it's very easy to use if we explain to the patient. And at the same time, it's not difficult to teach the patient how to adjust the dose of his insulin according to the blood sugar readings, and he can use the glucometer. Also, it's easy if we explain to him how to adjust the dose according to his meals and exercise. Regarding the hypoglycemia, we have to warn our patient, hypoglycemia is not a good thing to have. This is the main disadvantage of insulin, and we can avoid hypoglycemia by teaching our patient, and at the same time teaching him how to adjust the dose or decrease the dose of his insulin. And at the same time, if my patient, he has a lot of hypoglycemia, we need to be sure that he's not missing his meals by he should take frequent meals, 3 times, and the snacks between meals, and decrease the dose of his insulin before exercise, for example. If we need to calculate the dose of the insulin, as I said, it depends on the patient, his weight, and the type of diabetes. Those patients who are obese can use 0.5 up to 1 unit insulin per kg, per kilogram. If we decide to give the basal insulin, as I said, we'll start small dose like 10 units at night, and gradually we can increase it every 3 to 5 units. And if we decide to give the basal bolus insulin, we can give before each meal, and we give just 0.5 per kg, 0.5 units per kilogram, or you divide his weight by 2. For example, if he is 80 kilogram, we can start 40 units, and you can divide them 10 units basal, 10 before breakfast or before lunch and before meal, and gradually you start to increase the dose according to his meals and his readings. The premix insulin, if you calculate, and we decided, for example, to give 40 units, we can give 2/3 in the morning and 1/3 in the evening. And this is depending again on the patient himself, when he is taking his main meal, or depending on his lifestyle. Some patients who might like to give 50-50, but you can start with 2/3 in the morning and 1/3 in the evening. And after that, you adjust the dose according to his blood sugar readings. Controlling the fasting blood sugar, it's easy, as I said, by the basal insulin. Gradually, you have to monitor the fasting blood sugar, and if it continues to be above the target, we can increase the dose by 2 to 4 units every 3 to 5 days. There are too many examples how to adjust the dose, but nowadays it's very simple. If we are using the basal insulin, just one basal insulin, to monitor the fasting blood sugar, and once the fasting blood sugar be around 130, we keep the same dose. If it remains above 130, we have to, for more than 3 to 5 days, consecutive days, will increase the dose by 2 to 4 units. The postprandial blood sugar, if we are using the basal bolus insulin, we have to consider increasing the dose before the meal. If he is taking 10 units before lunch, and his postprandial blood glucose or before dinner blood sugar remain above the target, which, for example, we define it above 180, then we increase the dose by 4 units. In some patients, for example, if we need to use, especially in a pregnancy, if we are using the NPH, which is the intermediate insulin, and short-acting insulin, they can mix it in the same syringe, but sometimes we give the NPH at night, and we give the regular or short-acting insulin before each meal. The only difficulty sometimes is how to adjust the dose of pre-mixed insulin. It's very difficult because already mixed and it's a fixed dose. And certainly we can, depending on the pre-meal insulin, and if we are going to increase the dose, we have to be gentle depending on the sugar readings, and at the same time we need to remember avoiding hypoglycemia. Premix insulin, as I said, you give 2/3 in the morning and 1/3 in the evening, but at the same time, some physician might choose to give it 3 times daily, and you can give 1/3 before breakfast, and 1/3 before lunch, 1/3 before dinner. For example, if you are going to decide to give 30 units, 10 before breakfast, 10 before lunch, 10 before dinner. If it is just 2 times daily, 2/3 in the morning, 1/3 in the evening. Some patients, if we can start once daily the premix to see if the patient is responding. For example, at the main meal before dinner, we can start just once daily premix insulin and monitor his blood sugar, and then we can add after a few days or a few weeks the next. So it can be once daily or twice daily or 3 times daily. In a premix insulin, you can increase the dose by 10% of the original dose you decided. For example, if he's taking 40 units and you need to adjust the dose and his blood sugar is still high, we can increase it by 4 units. If he is on 10 units, we can increase it or adjust it by adding 1 unit every 3 to 5 days. The advantages of using a premix insulin is just minimal injection. It's not like the basal bolus insulin. It's not 4 or 5 times daily. It's just twice daily. The disadvantage is difficult to adjust the dose of the insulin. So there is no dose flexibility in a premix insulin. But for those on basal bolus insulin, which is now the favorable regimen, especially in young type 1 diabetes, and it's easy to adjust the dose according to their meals and according to their blood sugar, probably achieving better control than a pre-mix insulin. The disadvantage also of pre-mix insulin is probably the nocturnal hypoglycemia, because we don't know how to adjust the dose, and it's very common nocturnal hypoglycemia. It's not very good things for the patient to have nocturnal hypoglycemia, and we need to avoid it as much as we can by either decreasing the dose or having a snack before going to bed. We have a few things in diabetic patients, especially in type 1 diabetes, something called Somogy phenomena, dawn phenomena, and this is probably explained to us the early morning hypoglycemia, usually around 3 or 4 in the morning, followed by high blood sugar when the patient wake up, and this is certainly secondary to hormonal regulation. If we need to avoid these phenomena, probably we need to teach the patient. At the same time, we have to encourage them to check their blood sugar before going to meal, and probably the basal bolus insulin will be probably better than using pre-mix insulin. There are certain patients, as I said, apart from those they need insulin, they need it just in the hospital or physiological, like those patients, all pregnant women, they should be on insulin. Those patients with acute myocardial infarction or cerebrovascular disease, those patients admitted to the hospital with acute illness, for example, infection, or they are septic in the hospital, those patients going for an operation, they must be on insulin. Last thing, we have to remember that insulin is not the miracle therapy. It is good. We achieve the target. It treats the most effective, powerful medicine to lower the blood sugar, but at the same time, we need to explain to the patient the disadvantage, like hypoglycemia, increasing weight, and we have to explain to the patient that lifestyle modification, sticking to healthy diet and exercise is very important, even if he is taking insulin. Unfortunately, a lot of our patients, when we start insulin, they think they can eat everything. And that's why a lot of those patients, they are not achieving the target in spite of taking high dose of insulin, because he thinks that by taking insulin, I can eat everything. So his weight will go up and we will never achieve the target. So it's very important to explain to our patients, yes, you are on insulin, but you have to stick to a good, healthy diet and continue your exercise to achieve better control and also avoid hypoglycemia. A lot of things we have to also educate our patient to remember his insulin and not to take his insulin unless he is sure that he is taking his meal. And there is a recent study now, you don't need to take the insulin before meal, half an hour before. You can take it now with the new insulin, the analog, just when you have the meal or you have the food in front of you. If you forgot, you can take it after meal. But certainly, we need to educate our patient to have the meal in front of him before he is injecting his insulin, so we can avoid hypoglycemia. The other things we have to explain to the patient to keep his insulin in the refrigerator, and he should have his regular insulin injection, regular meal, and to continue his regular exercise, but to remember, if he is exercising, to decrease the dose of his insulin or to have extra food or snacks. Injection technique, the educator can teach the patient, but certainly as a physician, we have to explain to the patient it is subcutaneous, either take it around the umbilicus, on the thigh, or the arms. There are a lot of needle sizes, but certainly there is a small one, and it's very easy to inject. We have to fold the skin to grab the skin, subcutaneous, not deep. And at the same time, when we inject using the syringe or the pen, we have to be sure that we are, for example, counting until 10, until we are sure that we are injecting the right dose of the insulin. Also, it's important to rotate, not at the same side, to rotate the site of injection. Storage, as I said, it should be in the refrigerator, not to keep it in the room or outside the refrigerator for a long time. The other problem for in using or initiating insulin, a lot of our patients, they travel and the time sometimes change. So it's very important to ask the patient to carry his insulin in the airplane and explain to the crew there that I have insulin and it should be on the refrigerator, or he can now take a small bag which contain an ice, and we can keep, or it's cold, to keep the insulin, okay? And the other things, when they travel, to take their insulin, and also not to miss his meal when he injects his insulin to avoid hypoglycemia. For driver who are on insulin, it's very important to carry a card with him that he is on insulin. If he feels any symptoms of hypoglycemia, to stop at the side and take blood and take sugar, or to keep sweets in his car to avoid hypoglycemia. And thank you very much.